Good day. This is Dr. Ahmed Medhat al-Shafi'i, lecturer of otorhinolaryngology, Helwan University Faculty of Medicine. Our topic today, discussing the approach for cases with sore throat and pharyngitis. We're going to be through some concepts and ideas without getting into much depth, as further details are to be discussed through the special senses module. Start with the meaning of sore throat. It's a discomfort or pain, or as some would describe it, just a scratchiness in the throat, medically known as pharyngitis. Many medical disorders can present with this discomfort in the throat. Causes could be variable. The most common infectious causes are the viral, with the rhino and influenza viruses, 90%. Bacterial, which cover most of the rest, especially the strep, rarely diphtheria, and fungal infection in certain conditions. Some systemic diseases like leukemia, infection mononucleosis, agranulocytosis, and the ulcers in the throat, like aphthous ulcers. It may accompany many different conditions, but it will the patient will come complaining of discomfort in his throat. So the diagnosis will be on examination. Also, mouth breathers, they have throat dryness and soreness. So any patient with nasal obstruction due to an acute condition or a chronic condition will have this problem. Also, for some rhinosinusitis problems, where there is continuous drainage of the secretions from the nose as posterior nasal discharge, it will irritate the throat and will cause its dryness. So he will complain. The patient will complain with this discomfort. For the acute pharyngitis, it's a very common disorder. Variable etiological factors, as we described. The viral is the most common. Streptococcal pharyngitis with a group A beta hemolytic streptococci. It's received the most importance and recognition due to it's condemned to develop into rheumatic fever and glomerulonephritis as a complication of this infection. Also, sinonasal diseases and some injuries and chronic allergy can be a cause, as we described. Concerning these pathogens, viral infections, the adenovirus, rhinovirus, and the flu, some enteroviruses, which are less common, and mumps, herpes, rubella, and also an additive secondary bacterial infection may be added to this viral infection. Also, this group A is streptococci and the pneumococci. So in this diagram, some of these organisms are listed. Further details will be described. The viral infection as herpes, accompanying the common cold. Also, sometimes there is the herpes zoster and the chicken pox. Mostly all of them, they are vesicles. The herpes zoster is painful. The herpes simplex, mostly in the angle of the mouth, sometimes in the lips or around the lips. If it should not be left unrecognized, as these vesicles might lead to some scarring if secondary infected. Also, with the measles, there is a characteristic complex spots, which can be described more with the measles condition. For the viral sore throat, just congestion in the throat with the discomfort, with no apparent exudates or pus, just mild congestion and hypertrophy in the throat will be the mostly what we find on examination. This is concerning the vesicles of the herpes simplex, just circumoral or might be reaching the lips. The clinical features, it may occur as in different grades of severity. Mild infections present with discomfort in the throat, some malaise with low-grade fever. The pharynx in these cases is just congested, no cervical lymphadenopathy. In severe cases, the pain increase is added with odynophagia, which is painful swallowing, dysphagia, it's very hard to swallow, mostly due to the pain and congestion, with headache and malaise, and the high fever will lead to some dehydration and dryness in the throat. Also, these cases show erythema, exudates, and tonsillar enlargement, and it will show lymphoid follicles on the posterior pharyngeal wall, where the posterior pharyngeal wall mucosa will show some hypertrophy of the lymphoid follicles present. It will show some granularity. Whereas very severe cases show soft palate edema, uvula, and the upper deep cervical lymph nodes enlargement. Mostly on clinical examination, it's difficult to differentiate between viral and bacterial totally. Various steps must be taken through the history and examination, and sometimes some investigations. Where viral infections are generally mild and mostly rhinorrhea and some hoarseness due to dryness in the pharynx and the laryngopharynx, while bacterial, most of the symptoms are severe. Sometimes in gonococcal pharyngitis, which is rare nowadays, is mild and may even be asymptomatic. For the diagnosis, clinical examination will follow the history, taking further investigation as throat cultures and some viral smears, which is really indicated. This throat cultures can detect the group A streptococci, which is the commonest, about 90%. If we suspect on diphtheria, it needs a special culture media. And gonococcal pharyngitis need special technique and fixation for the culture, and sometimes it leads to failure to find any finding during this cultures, to find any bacterial growth. So mostly we think it's viral etiology. For the treatment, supportive care as proper hydration, rest, proper humidity, and humidification sometimes be needed, as some humidified oxygen, some lozenges for softening and soothing the throat. Sometimes it's too painful, we use anesthetic sprays like xylocaine spray. Antipyretics and decongestants will ease the symptoms. Antibiotics if there is bacterial infection suspicion. These show that severely congested throat with some soft palate edema and some tonsillar enlargement. Mostly it's diffuse congestion through the throat with no exudates over the tonsils. Could be viral and could be bacterial, or could start as a viral infection and develop into bacterial infection. For the chronic pharyngitis, where this condition might turn into a continuous or continuing problem. This pathologically can be determined as where there is hypertrophy of the pharyngeal mucosa. The seromucinous glands will be hypertrophied, and this lymphoid follicles in the posterior pharyngeal wall covering the muscular coat of the pharynx will be also hypertrophied. Two types are present with the chronic catarrhal pharyngitis and the chronic hypertrophic or granular pharyngitis. In brief, there is a cause that's persistent, and this cause is in the neighborhood of the pharynx. So, in chronic rhinitis and sinusitis, there is posterior nasal discharge. This causes the hypertrophy of the lateral pharyngeal band in the pharynx. So these pillars will be hypertrophied, which is the palatopharyngeal and palatoglossal folds will be hypertrophied. Similarly, with chronic tonsillitis and some dental infections, also they are responsible of this chronic pharyngitis and recurrent sore. Mouth breathing, it's for the exposure of the pharynx to air continuously lead to dryness, and this air will not be filtered and humidified by the nose due to a problem in the nose causing chronic nasal obstruction, like severely deviated nasal septum, hypertrophy of the nasal turbinates, blocking the airway, sometimes nasal polyposis. Various conditions might cause this nasal obstruction. So this air will not be adjusted to body temperature, and it will cause dryness, and also it's going to be susceptible to infections. So this mouth breathing problem need to be treated each according to its problem, its need. If there is some conditions treated medically, some conditions need surgical intervention. The problem might be in the nose or the nasopharynx. So if there is a obstruction in the nasopharynx, like hypertrophied adenoids, sometimes tumors also must be treated. Also, some dental conditions will cause this chronic mouth openers, and sometimes it could be habitual without any problem that are present. The chronic irritants with smokers and some cultures, they have tobacco chewing, also heavy drinkers, and too much spicy food will lead to this chronic irritation, leading to pharyngitis. Also, the environmental exposure to smokes and dusts, these fumes will be irritant. Also, some faulty voice production. With this could be like some sort of neurosis, where there's constant need to clear their throats, leading to faulty throat clearing, and sometimes faulty voice productions might lead to this. Symptoms will be discomfort in the throat. Could be more in the morning with a foreign body sensation in the throat, with the patient saying, I have a feeling of something in my throat, I cannot clear it or make it to go away. Even when drinking or gargling, it cannot go away, uh, with a constant desire to swallow it. Also, some sort of dysphonia might happen. The patient cannot be speaking or phonating well for a long time, due to the effort that he exerts on his throat and his airway, as his throat starts to ache. This voice might also be different quality, where there is a coughing, the throat is irritable, so it's repeated cough might happen. Sometimes could be also habitual from the patient, and uh, uh, sometimes this patient feel this gag reflex. The chronic catarrhal pharyngitis, where there is congestion of posterior pharyngeal wall, and some engorgement of the blood vessels covering this mucosa, and the pillars, the two folds around the tonsils, with the palatoglossal and palatopharyngeal folds containing the muscles inside these folds will be thickened. Also, mucus gland continue to secrete more mucus, so it will be covering this mucosa. With this increased mucosal secretions, need to more irritation. The hypertrophic or granular pharyngitis, this walls appear to be thick and edematous. The mucosa congested, with covering blood vessels are dilated. The posterior pharyngeal wall, it has reddish nodules, hence it gives the name of granular pharyngitis. These nodules, due to hypertrophy of the lymphoid follicles, which is subepithelial in the pharyngeal mucosa, which is normally seen in the pharynx, but it's exaggerated in this condition. The lateral pharyngeal wall bands also hypertrophied. The uvula might be elongated and edematous. For the diagnosis, history, examination, culture, and biopsy might be needed. Sometimes we start with empiric therapies. In most of cases of chronic pharyngitis, looking for the etiological factor, taking a thorough history, a full throat examination, lymph nodes, and nasal examination will also be helpful. Sometimes laryngeal examination might be needed, which need a special technique due to the position of the larynx. Voice rest would be advised. Sometimes, if there is some sort of dysphonia, speech therapy might be recommended with a specialist. And this is essential for those who use this faulty voice production and clearing the throat frequently. These habits might be some advice from this therapist. Saline gargles, warm gargles, and avoid irritants must be advised, and proper hydration is advised. Sometimes, to ease the symptoms and have some relief, might be need some local soothing treatments, like lozenges. Sometimes we use soothing natural food like honey. Also, proper hydration is advised, and avoid irritation. The bacterial infections, the mouth have a normal flora with gram-positive aerobic organism and also anaerobic organisms. As shown, streptococcal infection is the most commonly to happen, especially in kids with the group A beta hemolytic streptococci. Other streptococci might be involved, But they have been linked to severe pharyngitis and resistant to treatment, and sometimes have some complication like arthritis. So the group A beta hemolytic streptococci, it has an incubation period up to 4 days, from 12 hours to where fever, sore throat, dysphagia, pharyngeal exudates, cervical lymphadenopathy, rhinorrhea, cough. All of these symptoms might be present. It's uncommon in infants due to the presence of the maternal IgG, and also the pharyngeal receptors for some of this organism might not present yet. Some rapid tests might be needed for the enzyme immunoassay, rapid antigen test, and optical immunoassay. Also, the elevated anti-streptococcal antibody titr, not commonly used right now, and clinically we consider use this modified center criteria, where we where there is 4 components with a fever and absence of cough and exudates and cervical lymph nodes. Well, probability if it's presence of 3 of these components, 3 to 4, it's like about 50%. It's mostly is going to be bacterial infection. Antibiotics in patients with negative throat culture results has little or no efficacy, where penicillin, erythromycin, or cephalosporins, if the patient is allergic, is a treatment of choice, and the patient must be aware of that some organisms they have this beta lactamase, so it will not have an effect for penicillin won't have an effect. Well, complications for this bacterial infection: suppuration through the upper respiratory tract, starting with the middle ear, causing otitis media, and for the nasal cavity with acute rhinosinusitis, sometimes not suppurative with systemic problems like rheumatic fever and glomerulonephritis, where the rheumatic fever might also lead to rheumatic heart disease, valvular heart disease, and this is Grisel syndrome, where there's the atlantoaxial joint will have some subluxation and instability due to this inflammatory process nearby it, which there is patient will have this torticollis with deviation of the neck to one side, and there's no apparent cause for it, and there is and you might recognize that in the history will be some upper respiratory tract infection, and sometimes it will follow a head and neck procedure. So this is the Grisel syndrome. It's not common, but worth mentioning. For this criteria covering the rheumatic fever, we will not be going in depth. It will be discussed with the rheumatic fever and rheumatic valvular disease, where we have a major and minor criteria for the diagnosis. Mostly this can be carried by the pediatrician, but we must be aware of these risks and to be considered for the history if this patient was referred to a general practitioner or an otolaryngologist. Also, there is scarlet fever, with it's a special condition where this streptococcal organism produce an exotoxin. This patient will have sore throat, mostly can be diagnosed by others, like as a case of acute tonsillitis, but in addition he have a circumoral pallor. The tongue will show this distinctive finding. It will be strawberry tongue, uh, swollen red mottled, as in the picture described. This mottling will mimic a strawberry. Some red macules will apparent on the hard and soft palate. These spots sometimes present, sometimes not. Skin rash, which is mostly starts on the chest and trunk and spread to the face, palm, soles. Sometimes may be a face discoloration. To confirm the diagnosis by the swab and the culture and sensitivity for the streptococcal, and there is a test called the Dick test, and for can be used and send this for the lab. And treatment is the same as a case of acute tonsillitis. Again, with viral infections, but this is not the common and usual virus infection, with the herpes simplex viruses. Mostly type 1 affect the oral cavity. Type 2 is usually genital. The primary herpes simplex virus infection might cause gingivostomatitis with these vesicles covering around the lips and the gingiva. Rarely it might cause acute pharyngitis, most commonly in children from 10 month age to 3 years. The fever, the malaise, and pharyngitis. These vesicles will be diagnostic. It might bleed easily. Sometimes it will be covered in crusts. Sometimes may be secondary infected. Sometimes will show some ulcers on the tonsils, covered in exudates. With this acute illness, it will for over 7 to 10 days. It will evolve with regression rapidly and improvement. Rarely it might be disseminated to involve the central nervous system with very high mortality. With some patients, they have weak immunity and they are vulnerable to this complication for this virus to spread to the central nervous system, and the virus can be latent and reactivated later on with a variety of stimuli. So the virus will be dormant in some of the neural ganglia. Later on, might be reactivated and start to cause some sort of neuralgia, and also will form some vesicles. The treatment is a usual symptomatic treatment, and the use of antiviral like acyclovir, especially if the patient is immunocompromised. Measles, rubella, with some findings like Koplik spots, conjunctivitis, coryza with runny nose, and also this buccal lesions, these Koplik spots, and with lymphadenopathy. Symptomatic treatment. Sometimes super bacterial infection might cause further problems. Concerning this Epstein-Barr virus, in fact, the beta cell, also it's found to be a cause of developing some malignancies like the nasopharyngeal undifferentiated carcinoma and the Burkitt lymphoma. The Epstein-Barr virus discovered to be present in this tumor tissue, and to have some receptors and antigen on this tumor tissue. Hepatosplenomegaly might be present, as those patients with hepatosplenomegaly might be advised to avoid contact sports, as to avoid splenic rupture and bleeding, which could be life-threatening if not did not have a proper intervention at the proper timing. Diagnosis for atypical lymphocytes found on CBC, complete blood count with differential, elevated liver enzymes, monospot tests, which can be negative, by the way, in young age, children less than 10 years. So we add to the clinical, we add some labs. We find the antibodies, IgG and M, for the viral capsid antigen, with further details to be avoided. Sometimes PCR can detect the DNA, and sometimes antibodies against the DNA of this Epstein-Barr virus. Also, the cytomegalovirus, which is also a cause of this pharyngitis. Sometimes congenital, sometimes acquired infection. Sometimes cytomegalovirus causes 95% of the infection mononucleosis condition. Sometimes other organisms might also cause this infection mononucleosis. Also, like Toxoplasma, rubella, hepatitis A, HIV, and adenovirus. Where there is a febrile type with fever with a known cause, not responding to treatment. Sometimes with the adenose type with this lymphadenopathy, generalized, and anginose with multiple throat ulcerations through the throat, and ecteric type with the hepatic problem might lead to jaundice. This infection mononucleosis, sometimes called kissing disease, where mostly Epstein-Barr and cytomegalovirus atypical monocytosis with the monospot and Paul Bonnell test, with specifically the appearance of rash on the use of ampicillin, which does the most diagnostic. Sometimes the enlarged spleen and rash and jaundice also add to the diagnosis. Also HIV with signs mimicking the Epstein-Barr, with fever, malaise, arthralgia, lymphadenopathy, and the rash. Also systemic disease like the leukemia granulocytosis might be caused, need proper investigation, and also secondary bacterial infection might be fatal with these conditions. So help from an internist is advised for treatment of this patient, and proper diagnosis and waiting of the of our decision helping this patient. Well, for diphtheria and fast, mostly the site of the organism is the Corynebacterium diphtheria. It's a gram-positive aerobic organism where it has it's a toxigenic. It's produce a toxin. It's present in the oral cavity, oropharynx, nasal, laryngeal, and also genital. Low-grade fever, toxemia, lymph nodes, where formation of membrane, which there is some argument about the membrane between some clinician and the pathologist. Well, it's unilateral grayish, and it exceeds the borders of the tonsils. It's firmly adherent. If you try to remove it, it will be easily to bleed. Sometimes described as a true membrane, sometimes described as a false membrane, with arguments about it. The vaccine of the DPT helped to limit this disease. The complication for respiratory, cardiac, liver cell failure, some neurological problems with the post-diphtheric paralysis, and for the toxemia, mostly is the cause of this condition, this various conditions, where the respiratory, these membranes might cause choking and obstruction of the larynx, with some neurological problems like optic neuritis, and also lower respiratory tract infection, bronchopneumonia, and these membranes might cause lung collapse, which will lead to respiratory failure. For the cardiac affection, the toxigenicity of this organism cause myocarditis. Also, the vagal neuritis will lead to to make this cardiac problem much worse, leading to heart failure. Also, liver cell failure and nephritis. Well, neurological with the palatal paralysis, leading to nasality and regurgitation of food to the nose. Ocular with ocular motility for the cranial nerves, and also diplopia. For there is ophthalmoplegia, internal and external. With internal ophthalmoplegia leading to blurring of vision. Also, the pharynx and the larynx leading to dyspnea, dysphagia, and stridor due to laryngeal paralysis, and also affecting the intercostals and the diaphragm, will worsen this respiratory failure condition. Where is the differential diagnosis of membranes in the tonsil, with tonsillitis, the most common, also diphtheria, other mimicking conditions, scarlet fever, Vincent angina, systemic diseases, and infection mononucleosis. Also, fungal infection is commoner than most of these other conditions. And if there is an ulcer, sometimes the membrane grows to cover this ulceration if it's traumatic or malignant ulcer. The Vincent angina with this Borrelia vincenti, it's a condition this characterized by severe local pathology, and there is no general toxemia, but it's very painful throat, and general condition is fine. And this pain radiates to the ear, and there's some tender lymph nodes, fetor oris with very bad oral smell, and there might be ulcers over the tonsils and the palate and the cheeks and gum. Treatment is the same as any case of acute tonsillitis, but mostly it's a unilateral disease. So the killing pain is that's not related to this general toxemia. It's the most diagnostic finding. Also, other ulcers on the pharynx and the oral cavity, might be traumatic, mechanical, infective. Also, this sometimes malignant ulcers have different and specific findings, and sometimes dyspepsia might cause this ulcers, mostly called as aphthous. Aphthous ulcers. Mostly they are the commonest. They mostly in groups and painful, and sometimes might be large, continuous irritation, and continuously the patient try to touch it and to clear it and to soothe it with his tongue, which makes it resistant for some time, and the presence of some irritants might cause the problem to continue. Also, some malabsorptions and lack of vitamins can be a problem. Patient with supportive treatment, it will heal within a short period. Some pictures for the aphthous ulcer with various sites, and many numbers. Sometimes might be a little bit large, sometimes might be secondary infected and resistant for also the pertussis, where there's some stages in it: scatar, paroxysmal, and convalescent. It's rarely due to immunization, with this whooping cough. It's has a loud inspiratory voice that's distinctive, whereas there's catarrh stage with some fever and regular upper respiratory symptoms, and with irritant coughing characteristic with a disinspiratory sound, sometimes called as in Arabic called as su'al al-diki. And due to this mucopurulent exudates might be irritating, an irritative cough, and this convalescent stage, as this is mostly self-limiting, and nowadays it's rare. Gonorrhea also mostly asymptomatic, needs a special culture. Treatment is penicillin, tetracycline, cephalosporins. Rhinocleroma is endemic in some areas here in Egypt. It's rare. It's a chronic granulomatous condition, leading to first some formation of some nodules at early stages, starting from the nasal cavity up to the larynx, and secondary bacterial infection might happen with chronic adhesive form, and atrophic forms might be present, leading to synechia and adhesions in the nose. Also, it's a chronic condition, very hard to treat, as it's a chronic granulomatous disease. Syphilis, the organism is Treponema pallidum, with various clinical stages, with the primary and the secondary and the gamma tertiary syphilis, reaching to the aorta and the CNS. Well, the primary stage, this chancre, it's solitary, painless at the site of inoculation. Syphilis is an STD. It's the site of implantation in the throat. It might heal within 3 to 6 weeks. Also, it's distinctive on biopsy by end ulceratus obliterans, which is distinctive on sometimes on biopsy. Also, this disseminative stage with some skin lesions and lymph nodes, pharyngeal tonsillitis with these mucus patches, where, as shown in the pictures, with various erosions, and it might have a silver gray appearance with red margins, a really distinctive finding. Spontaneous remission might happen, but if there is sometimes latent disease, lead to gamma formation, this tertiary form with this granulomatous lesion, formation of this mass with a central coagulative necrosis, surroundings by this macrophage and fibroblast, sometimes affecting different places, sometimes ulcerate secondary bacteria infected, and the problems in the central nervous system and the aorta is the most threatening. Non-specific troponin antibody test, like the VDRL test and the rapid plasma reagent test, are the screening tests. Also, there is a confirmatory test, this specific troponin antibody test. Treatment is penicillin. Allergic patients use tetracycline and erythromycin. Fungal infections with immunocompromised diabetics. This candidal infections. Patients also on prolonged antibiotic therapies might have these fungal infections. Candida is the most common. Also, post-radiation HIV need a specific culture for it. Topical treatment for nystatins and Also, add oral ketoconazole. Sometimes, if there's a severe infection, might need some IV amphotericin B, which have some problems and need hospitalization for proper medication. Some mycosis might reach to the pharynx, esophagus, and there's different forms of fungal infections affecting the upper respiratory tract and the lower respiratory tract. These forms of moniliasis, malnutrition, hypovitaminosis, diabetes, AIDS, immunocompromise, post-radiation, and prolonged use of antibiotics are the most common causes of this. Actinomycosis, with the Actinomyces bovis israeli. While they are in the part of the normal flora, sometimes the present in the tonsils and periodontal space. It might cause deep neck infection with multiple small abscesses, ruptures, and forming fistulas. Sulfur granules might be characteristic of these ulcers. Treatment with penicillin, but for a long period, like 6 to 12 months. Tendency of recurrence, if not properly treated, is suspect. Also some granulomatous diseases causing pharyngitis, like TB and leprosy. This condition is not as common as it used to be in the last century. Specific tests and cultures needed, and a long-term treatment for all the chronic granulomatous inflammatory diseases, and for the tuberculosis and the leprosy, help from an internist. And sometimes the disease will be reaching some other sites, like the lung, and this nephromatous disease sometimes might affect some nerves. Also, long-term treatment needed to recover from this chronic conditions. Radiation pharyngitis, post-radiation, the oral and pharyngeal mucosa, high cell turnover and high cell death, and for atrophic changes by the effect of radiation. Treatment, some supportive treatment needed topically and systemically, as it will sometimes lead to xerostomia, which is very severe dryness of the throat. Proper soothing and avoiding secondary bacterial infection is our main aim. Stevens-Johnson syndrome it's an oxidative form of erythema multiforme. Following upper respiratory tract infection, and sometimes use of certain medications like sulfonamides, anticonvulsant, barbiturate. These vesicles and bully lesions in the skin and the mucosal membranes. It's commonly ulcerate and bleeds and crusts. There's some fever and pulmonary involvement. Mostly it could be self-limiting, but also this skin and mucosal lesion takes few weeks to resolve. Recurrence rate is high. Treatment is mostly asymptomatic, fluid and electrolytes, and avoid secondary bacterial infection, and the withdrawal of the offending agent. Reflux pharyngitis, with the acidity of the stomach, this acid get back to the esophagus and the pharynx. Well, on pharyngeal examination, interarytenoid erythema might be diagnostic. Um, Also symptomatic. Some symptoms might lead to this diagnosis. Um, long-term complaint without any signs of any infectious cause raise this suspicion. Also, it's reflux. It's one of the causes of forming of neoplasia in the larynx and the esophagus. Well, treated with mostly lifestyle measures and medications. We ask the patient to raise his head and have a proper hydration and avoiding some foods that will cause that will increase the acidity and will cause irritation to the stomach, leading to increased acidity. Raising his head and upper chest and neck while sleeping might ease this condition, as it mostly affects the patient while sleeping with different forms of severity. Diagnosis 24-hour esophageal pH monitoring. This is the most. Also, idiopathic pharyngitis with no obvious cause or source of this infection. So we say it's idiopathic, condemning the postnatal discharge, the reflux to be a cause. Sometimes dietary factors, patient with habit of too much acids and very hot drinks, some personal habits, and also smoking. Some medications and sprays might irritate. Also, some the use of cocaine and crack might be a cause. Reaching a diagnosis need to complement our findings, starting with history. We're asking about any symptoms for the common cold and change of voice, any systemic involvement, also for any abdominal pain or enlargement, any pain elsewhere, like on the sternum, or any findings of the patient will be by the in the history. We usually you take the complaint by the patient own words, and also to find the symptoms that he's complaining of, reaching for find the signs of this condition, starting with the simple examination of the throat and the nasal cavity, and the use of endoscopes, flexible endoscopes, rigid endoscopes, examining starting from the nasal cavity and the oral cavity, reaching down to the larynx, which could be all done by the flexible fiber optic nasopharyngeal laryngoscopy. Might be a little bit invasive, but sometimes it's mandatory for complete examination. Well, investigations like for hematologic and swabs usually needed. Sometimes specific hematologic tests for specific infections. The throat swab should be taken when there's suspicion of bacterial infection, with consideration that the patient must not be on antibiotics during this swab. Also this swab is suspected to culture. Sometimes specific cultures are needed. However, antibiotic sensitivity is important. Sometimes the patient starts an empiric treatment with a broad-spectrum antibiotic until we find this antibiotic. We recognize this organism, and we recognize it has a certain high sensitivity to a certain antibiotic, and we will decide its suitability for his condition. Sometimes patient might be allergic to penicillin. Sometimes as a choice will need to shift to other drugs. Also, erythromycin has shown some resistant strains, so a proper antibiotic sensitivity is advised. The virus route continuous gargling with water and salty water and symptomatic treatment is advised. For strep infection, antibiotics needed. The choice for penicillin V and shifting to amoxicillin with children, and if allergy, erythromycin might be needed. Treatment duration up to 10 days. Other causes like mononelases, actinomycosis, leukemia are treated each has a specific treatment. Where for mononelases, it's advised if the patient is antibiotics, it should be stopped if it will not cause a further problem. And local treatment, sometimes systemic, might be needed. And also this the correction of the general condition causing this problem, for this immunocompromisation is needed. For the acute tonsillitis, which is the most commonly recognized, the palatine tonsils could be acutely inflamed as a part of the pharynx. Viral infection, secondary bacterial infection, the crypts inside this lymphoid tissue inflamed and obstructed, leading to debris trapped inside the crypts, and the antigens for this antigens from this organism might be expressed on it. Most common pathogens like group ABT, Hemolytic streptococci, and others. Different types with superficial tonsillitis and membranous, follicular, and parenchymatous. It varies according to the degree of involvement. Clinically, mostly school-age children, sore throat, dysphagia, sometimes trismus, fever, reading up to high-grade fever, and anorexia. Other symptoms like headache, malaise, and backache. Earache due to referred pain. Also could be due to concomitant acute otitis media, which also might be a complication of acute tonsillitis, or the same cause. Halitosis, very bad odor in the mouth, abdominal pain, which rarely it might have with any case of fever, with acute infection, might have mesenteric lymphadenitis to be noticed and recognized. Signs vary according to this pathological type. Lymph nodes might be enlarged. Differential diagnosis might be considered, especially if there is membranes, especially with other causes of sore throat, as this. Well, those signs: tonsils is uniformly enlarged and red, bad odor, pillars are petrified and hyperemic, tonsils red, swollen, yellowish spot, purulent material covering it, especially from the opening of the crypts. Tonsils might have a whitish membrane covering it. Tonsils can be easily wiped with a swab, removing this membrane. uh, and also there's enlargement of the tonsils and congestion, sometimes reaching up to the midline. Also sometimes edema of the uvula, the soft palate, and the lymph nodes, enlargement and tenderness, also a common. Well, recurrent attacks of acute tonsillitis might happen with the advice for removal of this tonsil. These tonsils, if there is within 1 year, at least 7 episodes, or 2 years, at least 5 episodes per year, or for 3 consecutive years, 3 episodes every year. Diagnosis clinically, throat swabs, sometimes antigens and blood tests needed. Sometimes patient might have positive cultures with no enlargement of other tests, with no elevation in this ASOT titr. This could be the carrier state. Other differential diagnoses for acute pharyngitis and membranous condition. Also peritonsillar abscess, which is the quinsy, might be discovered, and sometimes leukemia and lymphoma present with similar findings with tonsillar enlargement and sore throat, and also fever and malaise. So might be this is for the tonsillar grading system. Just information to be added. This is the appearance of the X-rays coming from the crypts of the tonsils. Hypertrophied tonsils, edema of the uvula are common signs. This is acute cases, sometimes spots over the palate, lymph nodes enlarged and tender, also enlarged and covering with might lead to developing rheumatic fever and glomerulonephritis. Complications: acute infection turn into chronic with this recurrent acute attacks. Incomplete resolution is the main cause. Chronic infection in this lymphoid follicles, microabscesses form, peritonsillar abscess, quinsy, parapharyngeal abscess, retropharyngeal abscess are possible sequelae, especially if there is immunocompromisation or severe infection. Lymph nodes might be a cause of suppuration. Otitis media and the rheumatic fever, glomerulonephritis, and endocarditis might be a sequelae. Febrile convulsions might happen. Retropharyngeal abscess as a complication of this condition. Peritonsillar abscess, the quinsy, where in addition to the finding of the previous symptoms, there is a trismus, there is pain and dysphagia, very bad odor and muffled voice, sometimes described as hot potato voice. Also the lymphadenopathy. Usually it's a differential diagnosis of acute tonsillitis, but there is formation of this abscess lead to unequal enlargement of one of the tonsils. So might also consider some tumors have this unequally enlarged tonsils. There is some lymphomas inside or some tumor pushing the tonsil, and also some carotid aneurysm, as the carotid will be lateral to the pharyngeal constrictors, just lateral to the tonsil. Also complications, infections to be extended, further in the neck with the deep neck infections, or sometimes systemically. Also this quinsy, which is unequal enlargement of the tonsils, where there is bulge on the soft palate on one side, and this tonsils is pushed to the midline more than the other, and the uvula and the palate pushed to the opposite side. Some picture for the quinsy, where there's development of abscess in this peritonsillar space. Also, considering for strep infection, the use of fever and cough, absence of cough, might differentiate if there's is mostly strep or not. Cervical lymphadenopathy, and at the end we might need to complement this with throat swelling. Management with bed rest, hydration, oral hygiene, sometimes analgesics needed, antibiotics, mostly broad spectrum, mostly to cover the streptococci. Penicillin is the best, clindamycin and erythromycin for allergic patients that are allergic to penicillin. 7 to 10 days is the duration of treatment, and tonsillectomy is advised for chronic tonsillitis of this condition recurring according to what we discussed in a slide previously. Well, on chronicity, recurrent acute attacks, obstructive sleep apnea due to enlarged tonsils blocking the airway, dysphagia, and similar symptoms to before, and this it have sometimes the scripts in the tonsils show irregularities, hyperemia, so is similar symptoms from the acute, but this persistence of this infection. Sometimes it could be polymicrobial infection. These microabscesses might be form fibrous tissue, as these follicles in the tonsils might completely form into these microabscesses. Sometimes could be just mild subclinical recurrent attacks. Children and young adults usually affected. This chronic infection in sinus or tooth might be as this cause of this factor. It might be a causing factor for this condition. Subtypes of the follicular and parenchymatous and fibroid tonsillitis, similar to this acute tonsillitis, but considering this formation of sleep apnea with a severe enlargement of the tonsils, it's a problem to increase the pulmonary hypertension, leading to further problem, and sometimes in children might be raised this. Sometimes it's a cause of sudden infant death if not properly recognized. Clinical features, as we discussed before, sometimes formation of this tonsillis with these secretions might be calcified and be form like a stone to be sometimes can be easily removed by the patient himself from the tonsils. While in examination, similar findings as acute tonsillitis. Management, conservative treatment, long-term antibiotics might be needed, and tonsillectomy might be. For a case and some questions over one of the cases that might be in the exam, presented in a previous exam. A patient could be a male patient, 23 years old,
presented with high-grade fever and sore throat, and muffled voice, whole potato voice, and upper deep cervical lymph node enlargement. On examination, this revealed this picture with enlargement of one of the tonsils and enlargement and deviation of the uvula and the soft palate pushing to the other side. This mostly question the probable diagnosis. Uh, these others could be some of the differential diagnoses, with the exception of the tonsillis. The quinsy is the most problem, as it usually comes after the acute infection. How we can describe this pathological condition, where there's pus collection in the peritonsillar space. Also, sometimes a question might have what are the clinical findings of this condition? Well, to choose, all of these findings could be present with this condition. Also, otorrhea might be present if there is acute otitis media, but it's not discussed. It's not. There is might be severe otolgia with this condition, but otorrhea must be there is acute otitis media. Could be accompanied with this condition, but it's not addressed in this case. That's why we address this as the wrong answer, as this question is we want to find this the one the unrelevant finding, which is not possible line of management. Biopsy is not needed. All of this supportive treatment might be needed. Sometimes you might need to drain it, but biopsy is not needed for this. And also tonsillectomy is advised after this condition, especially if it's repeated. And this last question, complications might be a variable, but this is not a pre-malignant condition, so this one is excluded from our choices, as the others are mostly related to most of the infections and suppurative infection mostly. And further details could be added in the ENT and special sciences module. I hope it was the information was not into too depth. We just giving an overview of our condition, and some details must should have been added, so it will give some relevance to this topic. Thank you very much.